Thank you very much. And the other thing is, and I forgot to mention this earlier, is that we're grateful that this Georgia Colorectal Cancer Control program, this TeleECHO series, is brought to you by Georgia Core with funding from the Centers for Disease Control. It's a great program. I'm glad to be able to be a part of it. So along with me today, we'll have Dr. Islam, who will be serving as co-facilitator of the TeleECHO session, and he'll be wrapping it all up when we're done. Again, just put your name in the chat along with your clinic and your role, if you would, but your email address. That way we can kind of keep track of who's involved. Let's see, we're ready to go over the agenda for today. So we've gone through the introduction. The didactic will be about a 15-minute presentation from Dr. Francis Colangelo, and we'll introduce him shortly. It'll be followed by a case presentation with providers from Dawson Medical Center, including Dr. Dyer, Beth, Webb, and Dr. Sane. They'll be introduced by Dr. Robbie Amin, and we'll get to that in a little bit. And then we'll have some discussion at the end of it, hopefully with some robust questions from the community and opportunities to share your own experiences. So let's see. In addition, I just want to introduce some of the other team members. We have Dr. Sama Ibrahim and Christopher Turner, who are managing the controls and the technical side for the presentation today. And then we will move along pretty quickly here with a few summary statements about Project ECHO. This is not news to most of you who've been involved with the Project ECHO series before, but just a reminder that Project ECHO is built on the notion of moving knowledge instead of people. ECHO stands for Extension for Community Healthcare Outcomes, originated in the University of New Mexico. Next slide, please. This one for TeleECHO for colorectal cancer screening. All of the purpose of this is for education and quality improvement purposes. And because of that, all sessions are recorded and archived so that you can review them later if you need to. And by participating in the sessions, you're consenting to being recorded. We remind you that these are not consultations, these are education services. So this is not the time to share PHI in the discussions. If you have any questions about this, you can of course email those to AU_CRCS or CRC screening at augusta.edu. Of course, you can always put it in the chat as well. Next slide, please. So we do collect data, begins with the registration process, but we also collect data from the surveys, the chats, everything is recorded. We use this primarily for development of new program materials, but also for our own internal communication and performance improvement activities. Next slide, please. Just some general Zoom reminders. Mute your microphone when you're not speaking, unmute when you do speak. The chat is open and available for questions at any point during the entire session. And we do ask that if you have questions that you would like to ask, that when the time comes after the presentation, that you raise your electronic hand, and you can do that by hovering over the reactions button on the bottom of your screen and then clicking on the raise hand icon. Once you're recognized, then you can introduce yourself, your name, your clinic, and ask your question. Please use your cameras. We'd like for you to keep them on at all times if possible. That way we can see your face throughout the presentation. If you have broadband issues, and we understand that is a reality where we live, we understand if you have to mute your camera for the purpose of being able to stay connected. Gallery view is helpful so you can see as many of the participants as possible. And of course, you can always chat with Sama or Lorianne during the session if you have questions or technical issues. Let's see, next slide. Again, this is the screening survey. I'll ask you, if you have not completed the survey, to go ahead and scan that And perhaps you can open that link up on another device. And we'll give everybody just a couple of seconds who may have not had a chance to do that to get that scanned and get that open, and then we'll move forward. All right. Well, at this point, it's my pleasure to introduce our featured guest today. It's Dr. Francis R. Colangelo. Dr. Colangelo practices as an internist and serves as Vice President and Chief Quality Officer for Premier Medical Associates. In 2021, he took on the additional role of Director of Outcomes Office for the Allegheny Health Network, with the goal of leading the change to a value-based care system across Western Pennsylvania. Dr. Colangelo is currently on the steering committee for the National Colorectal Cancer Roundtable, and he serves as co-chair of the Professional Education and Practice Implementation Task Force. His talk today will be Assuring Successful Colorectal Cancer Screening Rate. This presentation will last approximately 15 or 20 minutes, and then we'll have hopefully about 5 minutes for questions. After that, then we'll follow up with a case presentation. But at this point, it's my pleasure to turn it over to Dr. Colangelo. Welcome, sir.
Thank you, Doug. And I just have to apologize. I just noticed about 15 minutes ago that it said I'm the director of a New Hampshire state program. I'm not sure where that came from. I'm in the Pittsburgh area, so thank you for that nice introduction. So, and I have a lot of slides today, but I talk fast. We're going to power through these because I want to share a lot of information with everyone. So, will you advance the slides for me? Okay, just an outline of today's talk. Go to the next slide. So I'm sitting about 15 miles east of PNC Park in Pittsburgh, the prettiest ballpark in America with the worst baseball organization in America. So that this was probably on fireworks night. It would be the only reason why the stadium would be full at this time. So next slide, please. And I work for Premier Medical Associates, a multi-specialty group that's been around for almost 30 years, a little over 100 providers equally divided by primary care and specialty. And we are part of the blended health organization between Highmark Health, which is the local Blue Cross and Blue Shield affiliate, and the Allegheny Health Network, which is the provider arm of the organization. And next slide, please. Just a little map of our Pittsburgh area where we serve. I mean, my practice is located, we have an advantage. We're in the eastern suburbs of Pittsburgh in about a tight 15-mile radius, 7 busy adult primary care offices. So when we want to begin a quality improvement project, it's very easy for us to visit the offices, entertain everyone, get everyone together, explain what we're doing. But an interesting part about the offices too, I mean, it's not one homogeneous population. The two practices at the far western side of the circle are closer to the city of Pittsburgh. So about 25% Medicaid patient, 25% Black and African American patients at those offices. The one on the farthest east side of the circle is the beginning of Appalachia. It's like 99% rural white. So even though it's just 15 miles apart, there's a lot of difference in the patients that we serve across our practice. So next slide, please. I just wanted to go over some general CRC statistics and talk about the status of screening in the United States. So it's estimated in 2022 by the American Cancer Society, there will be over 150,000 cases this year and 52,000 patients dying of colorectal cancer in the United States, which those are both shameful numbers since this is a disease that we could greatly reduce those numbers if adequate screening occurred. So next slide, please. But it's not all bad news regarding this. I mean, in the area where we began screening, thankfully, there has been a reduction in incidence rates since the mid-1970s over time, and a great reduction in death rates from colorectal cancer over the last 40 years also. So it's not all bad news, but we could do even better with colorectal cancer screening outcomes. So next slide, please. And the thing that is bothering us especially is the increase in colorectal cancer in younger individuals, those under the age of 50. There has been a 44% increase in colorectal cancer in patients under the age of 50 in the last 2 decades. Most of this in patients between the ages of 40 and 49, but some are present in patients in their 20s and 30s even. So next slide, please. And the BRFSS most recently said about almost 70% of Americans between the ages of 50 and 75 are up to date with screening. And next slide, please. And the uniform data system, which would affect health centers, there was a dip during the 2 years of the pandemic, but hopefully we're seeing some recovery in 2021, and next year we'll try to get back up to those pre-pandemic numbers of screening across health centers. So next slide, please. So next slide, current state of screening. According to the American Cancer Society, since 2018, those between 45 and 75 should be screened, and we should use a shared decision-making process to decide those between 76 and 85 who still need to be screened. The USPSTF came out last year, gave a grade A recommendation to screening those 50 to 75, a grade B recommendation for those 45 to 49, and that we require shared decision-making for those above the age of 75. And then we have to worry about increased risk individuals, those with family history of cancers or polyps and inflammatory bowel disease. These patients need to begin screening earlier than the standard guidelines based on when their family member was afflicted by the disease. So next slide, please. And we have options for screening. We can do both stool-based tests as listed in the table and structural or visual exams, including colonoscopy, CT colonography. So those are our screening options that are available according to the most recent guidelines. And next slide, please. And this was a classic study about 10 years ago that showed that offering patients more choices can help to increase the rate of CRC screening. When patients were only offered colonoscopy screening, about 38% of them were screened. If they were offered fecal occult blood testing, 67% were screened. But if they were offered a choice of either, 69% agreed to screening. That was a statistically significant increase in the completion of screening rates when they were offered choice. So that's something important with all providers who are offering screening to patients. So next slide, please. And I'll go on. The NCCRT, the National Colorectal Cancer Roundtable, was co-founded by the American Cancer Society and the CDC in 1997. And it's a collaborative partnership of over 150 organizations whose ultimate goal is to increase the use of proven screening tests among the entire population for whom screening is appropriate. And there's a link to a resource center that I'll describe later in the talk how beneficial it is. So next slide, please. And over time, the National Colorectal Cancer Roundtable has offered hints on how one can increase screening rates on a systematic way across your practice or organization. And there's some variation of this steps that an organization has to make a plan to increase screening. They should identify a team of champions who can lead the charge. They have to make it a policy that patients whose screening is indicated should be screened. And then we have to coordinate care. We have to follow up on abnormal tests. We have to find patients the ability to get colonoscopies if perhaps they don't have coverage. So it's a continuous iterative cycle that we have to work on improving the rates of screening. So next slide, please. And last year, the NCCRT said there are 3 current priorities that are being further worked on right now, but they were: number 1, we need to begin on-time screening as soon as it's eligible, whether a patient is of average or increased risk. There needs to be timely colonoscopy follow-up to positive or abnormal non-colonoscopy tests. And we have to understand and address the source of colorectal cancer disparities across the country. So those are 3 things. So I'm going to talk about how my practice increased screening rates and how we are addressing these priorities during the rest of the discussion. So next slide, please. So PMA is the initials of my practice, Premier Medical Associate. So next slide. So in the summer of 2012, I was at a CME conference, heard Dr. Richard Wender, who was a past Chief Cancer Control Officer for the American Cancer Society, led the roundtable for 9 years, and he's now the chair of family medicine at the University of Pennsylvania. He said, you got to measure your practice's screening rate. It's probably not as good as you think that it is. And I sent a text message to my quality leader who said we're at 57.5%. He said, you can get good screening rates if you only offer colonoscopies. You're not going to get great screening rates unless you offer choice in screening. So I had Dr. Wender come to our practice and gave a grand rounds presentation, and we give the date of January 1 of 13. He lit the fire under all of us as to how it was important to increase screening rates. So next slide, please. And what did we do? I mean, in 15 months, we climbed from 57.5% to 75%, and then we plateaued. for a couple of years. We couldn't get over that mark. We were shooting for the 80% screening goal that many organizations aspire to across the country. So what did we do? We did multiple PDSA cycles going forward. We started doing monthly progress reports on how we were doing towards our 80% goal. And we started transparent provider reporting. This was the first time in our physician bullpens where our medical assistants could see. We had each provider's unblinded names, how they were doing on screening rates, how they were doing compared to the 80% mark. And this was the first time. It was an interesting reaction that happened. The providers who were below the 80% mark almost had a rebellion across the practice. They blamed me for embarrassing them and hurting their self-esteem, called our physician president of the practice, says, "You have to stop Frank. He can't do this any longer." The president of the practice says, "Order more colon cancer screening and your self-esteem will be helped." So we didn't back off from transparent reporting, and it's become part of, we do this for diabetes control, hypertension control, or every chronic condition, immunization rates. So this was the first time that we proved it was successful. The other thing that we noticed was about 1/6 of our patients who choose to be screened for colorectal cancer choose to do an at-home test, a FIT test. And a problem about that's great that they're screened, especially if it's negative, but 366 days after the last screening, the patient is no longer considered to be current with screening. So we developed a FIT registry, and next slide, please, in which we kept track of those 2,000 or 3,000 patients who do that way. And on the anniversary month, 1 month before their anniversary of the last test, we mail out the FIT kit with a mailer that's stamped and addressed to come back to the practice. And about 90% of those patients quickly complete the test. And then we have phone reminders for those who are delaying. But this started to drive rates as we were not having patients fall off on the other end of the cycle. Next slide, please. And then we did a pilot with Exact Science, the company that offers Cologuard with their multi-target stool DNA test. And this emphasized the need for providers to offer patients choice in screening. There were about 800 traditional Medicare patients who, after 4 years of us approaching them, you have to do something, they still hadn't done it. We worked out that they received a letter, they received a kit from Exact Science, and almost 160 of those 180 patients, so 20% of them, completed the Cologuard test at that time. So they found that way of screening to be more palatable, more willing to do. And on that group of patients, about 20 of them had abnormal tests, and we found 2 early cancers and 3 advanced adenomas among those patients. So it was a good thing that we did that pilot project. We made a difference for those patients. So next slide. So it took us until October 2016, but we finally hit an 80% screening rate across the practice, and we have maintained that. This was a data that we had with practices we share across the country at the end of 2021. So we stayed above 80% even with the pandemic in 2020 and 21. So we ended last year at 83%. So we were pleased with that. So now I mentioned the 3 priorities that the National Colorectal Cancer Roundtable, how have we addressed those? So next slide, please. In 2013, one day I was noticing a number of patients that my partners had positive FIT tests that I saw no follow-up colonoscopy, and asked our lab director, give me a list of every patient who had a positive FIT test in the last year, and did a chart review and found that only 57% of those patients had completed a colonoscopy. So we started an effort. We came to everyone and said, we have to improve this. We can't allow the patient to say to you, "Oh, I had a bleeding hemorrhoid that day. Can you let me do the FIT test again?" Which was a common thread that came through, explaining that these patients all have to have a direct visualization exam, a colonoscopy, to complete their screening. So we had standard messaging for providers and patients. Providers would say to patients before they gave them a FIT test, "I will allow you to do a FIT test if you promise me that you will do a colonoscopy if the result returns positive." Every Monday afternoon from our lab, I get a list of the 5 or 10 patients who tested positive during the previous week, and track and make sure that those patients have been notified of that abnormal result. There's a banner put on our EHR that the patient has had that. And if the patient hasn't scheduled a test within a month, we send them a personalized letter from their primary care doctor saying, "This is a problem, you had a positive test, you need to have a colonoscopy performed." So next slide, please. So over a 7-year period of time, we drove over an 88% completion rate of patients who had colonoscopies after a positive fit. Across the nation, that number is often less than 50%. And when you're getting above 80%, that gets getting into the range of Kaiser Permanente and some of the really strong navigation sites that work on this. But just an interesting thing, during the first 18 months or 21 months of the pandemic, only 55% of our patients with a positive test completed a colonoscopy. We kept working on those 136 patients. Yeah, they may not have had as timely as a colonoscopy we want, but eventually 72 more of them completed their screening. So we were approaching that 80% mark of our patients. So the pandemic had an initial effect because patients were afraid to go out and get other testing done. But eventually we got many of those patients to complete their screening. So next slide, please. The other thing they mentioned, the roundtable says that we need to start screening at time. So last year it was suggested that we start the screening age at 45. Well, we had our data in our 45 to 49 age group at the end of December of last year. Only 35% of those patients have been screened. And when you include those in the overall screening rate, it drops us from 83% down to 77% because of that low number. So what did we do? Next slide again. So there were over 2,200 patients who were either due or overdue for screening. So we sent an automated voice call or text message to these patients, had our fit vendor mail these patients a kit late in, it should be January of 22, not 21. Sorry for that typo in the slide. And then followed up about a month later with an automated text reminder for those who hadn't completed. And almost 20% of those patients completed the testing without provider discussion, just with the mailing. 19 positive results occurred. 5 advanced adenomas were found. If you add these individuals together, so next slide, please. We increased that screening rate in a month and a half from 35% to almost 54% in that age group. And our overall screening rate climbed by about 0.5% because of those individuals doing this screening during that period of time. So I hope that we assured some on-time screening for that younger age group who we hadn't been concentrating on before. So, and then the next slide, and we want to work on addressing disparities. So this is the first time, this was the first condition that we measured whether there was a disparity in our screening rates between our Black and African-American patients and white patients of the practice. We found that there was, and I'll tell you what it was in a minute. Educated the providers over the fact that there was a disparity, started dashboard displays with how we were doing over time, and we added some on live patient navigation calls for those patients who needed assistance. And next slide. From the Resource Center of the National Colorectal Cancer Roundtable, there's great resources with market testing or messaging that has been performed. And they released a guidebook this past year in which they talked to Black and African-American patients, and the messages that resonated with them the most is the one that's present on the screen. And if some of you can't see the slide, I'll just read it. Did you know that colorectal cancer is the 3rd leading cause of cancer death in both Black men and women in the United States? Colorectal cancer can be caught early or even prevented through regular screening. Most people should begin screening at the age of 45. So that was the messaging that we used for our live calls and any robocalls that occurred. And did it make a difference? I'll show the next slide. In a 6-month period of time, we had a 9% difference in our screening rates, 82 to 73% at the end of June in 21. Then it closed to 2% by the end of December. So that was when we focused the effort and closed it. And we're not going to stop with these efforts. And we see those 2 lines touching each other. So we feel proud on the work that we did for reducing disparities. And then last slide that I have before questions is coming up here. So they have just released about a month ago. The National Colorectal Cancer Roundtable updated their steps guide for increasing colorectal cancer screening rates. Fabulous resource. I recommend downloading it so that you can look it over. There are case studies from physician practices, case studies from health centers and large organizations that have increased screening rates. So many tools, things that you can borrow from other successful organizations that have driven great screening rates. And I hope that this is something that you can look at and maybe help your own practices efforts going forward. So I think that was the last slide before any questions, but sorry if I took a couple minutes longer than I should have. Sorry about that. So.
Thank you, Dr. Colangelo. That's terrific. It's a lot of information, particularly interesting to see the closing of, or at least the approaching of the closing of the black-white gap. I don't see any questions in the chat. I would like to see if somebody can copy that link to that updated steps guide and put that in the chat for us, please, from the slides while we're talking. I see Dr. Desai has his hand raised.
Okay.
Yeah, thanks again for coming to talk to us. I think it was a really interesting presentation. I especially liked how you guys were able to reduce the disparities amongst the different socioeconomic groups. One question that I had, and something that we see, and by the way, I'm one of, like, I work with Dr. Hodgson actually with reducing colorectal cancer disparities in rural clinics in Georgia as part of the CDC program as well. So one of the things that we're seeing with that program is that there's a big disparity between an insured program patients and uninsured patients. Did y'all notice the same thing, and what did y'all do to try to reduce that disparity?
Yes, we did notice that. And thankfully, I mean, we're fortunate. I said that, our practices are, greatly disparate across the thing, but we only have about a 1 or 2% uninsured patient rate. So that's one thing I can say that I feel fortunate that hasn't been a huge barrier for us, but it's a problem that we need to address. I don't have a slide showing the difference, but yeah, it's a problem, but thankfully for our particular practice, it's not a huge problem. So, yeah.
Let's see, there's a question from the Dawson Medical Center.
I'll defer to Dr. Hotz because it may be for the same question.
Dr. Hotz?
Are you on mute, Jim?
Great talk as usual, Dr. Colangelo. I was interested in that one slide you showed about the feedback by provider. We get overwhelmed with numbers, and it seems to me that some type of graphic display, where you had, it looked like you lined up all the providers and showed the gaps that were there. And yeah, that one right there.
Well, these are across organizations, Jim. So those aren't providers there. So,
but they're organizations. But
right.
It seems, and I think I've seen a slide where you do it by individual providers, don't you?
Yes.
Yeah, and it seems to me that that is kind of the money slide to me, because it's so easy to see where you sit. How much, and it sounds like you got a real bite as far as the interest of the providers, because they started complaining about their numbers. So how do you present that graphically? Do you have somebody that does that? Because it seems to me to be an extraordinarily effective way to do it, and you do it monthly. Do you think that's one of the big motivators about providers and their competition interest?
I do, and I tell a follow-up story just to take a minute. I said we do this not just for colorectal cancer screening, but for other conditions. We had a project where we were working on improving blood pressure control rates, and a couple of our offices were advantaged by a new program that we had to help with decision support. So we stopped publishing the blood pressure control rates for all of the offices for about 4 months because we didn't think it was fair to publish the ones that weren't advantaged. And the providers at those offices actually complained, where's our blood pressure control graph? So like they went from hating it to 4 years later complaining that they weren't seeing how they stood on the graph. So it just became part of the culture of the organization that people look forward to these every single month.
So you think that monthly reporting in this kind of one sheet, there it is, because it seems to me it's so easily to kind of look. You got your red line there, you either above it, below it. And so, this to me seems to be extraordinarily. Do you know any other organizations that have copied this or used this type of reporting format?
Oh man, we're big. Our group is big members of the American Medical Group Association, and this is where we learned this from. There's one group that not only posts these in their physician bullpens and for their MAs to see, they hang these in the waiting room for their patients to be able to read them. So it's like, we haven't gone that far yet, but that's, this is a common thing that's happening across many high performing organizations across the country. Yes. Yeah.
Thank you.
That's great. So Dawson, you still have your hand up. Robbie, did y'all have a comment or a question?
Yeah, and thanks so much for your presentation. It was awesome. And one of the things that the question that I'm going to ask is about the FIT registry, but that's also leads into one of the hardest things that there is to implement, and it's obviously it's in the steps manual as well, is that the patient reminders aspect. The EBI, that's probably the hardest EBI there is, that I feel that to get that. So that's actually very interesting, and I think we're going to try to do that here. But the question that we had particularly was, what kind of cost association did you see with that in terms of having to mail those fits out? Any things like, you know, loss of that they didn't send them back when they didn't, or was there a burden on you guys?
Well, you know, we were doing it internally, but it was a big time, our requirement for our staff that was doing it. So we actually have our practices fit vendor do it for us on a regular basis over a period of time. And it's for the whole thing, the kit, the mailer, the addressing, the stamping, them working it, them doing the navigation. It was like $13 a person is what they sent out. What we decided as a practice, we have risk contracts with Medicare, with our large commercial plans. We've almost felt this was an investment. We were going to reduce late stage colorectal cancer. So we thought that investing in this was going to pay off with reduced cost of care related to colon cancer down the line. So,
Yeah, thank you so much.
yeah, thank you.
Which really gets to the value-based performance efforts that we all feel are important, very difficult to implement sometimes, particularly when there's provider resistance. So the combination of the scorecards, the recognition that this is an investment, we've got to spend a little money, but we, in a value-based world, that should ultimately return to some reward for the organization. That's great.
Thank you.
Well, at this point, I'm going to turn it back over and I'm going to introduce Dr. Robbie Amin, who is a clinical liaison for Horizons Community Solutions, formerly known as the South Georgia Cancer Coalition. And Dr. Amin, you're going to introduce our presenters there at Dawson Medical Center, part of Albany area primary health care. I'm going to turn it over to you.
Thanks so much, Dr. Patton. Yep, so sitting next to me here is 2 out of the 3 main providers here at Dawson Medical Center, Dr. Dyer and Beth Webb. And overall today, I'm going to talk about provider assessment and feedback. I'm quickly going to introduce the topic itself and just get into a background of it. And then we'll quickly get into the discussion portion, which I think will be beneficial and take the majority of the time. But next slide, please. So wanted to just do an introduction of what is provider assessment and feedback. I know Dr. Colangelo mentioned it and its effectiveness, but it's evidence-based intervention based on the CDC. It's focused on delivering information about clinical performance and particularly screening numbers for clinics and individual providers. Here at AAPHC, particularly at Dawson, because we're an FQHC, a lot of the numbers are focused on UDS measures. It establishes goals and motivates clinicians and clinical staff. That's the basis behind it, and its ability to show providers precisely how many patients are getting screened and are receiving follow-up care. So, and we'll get into that a little bit as we go. And then finally, it helps inform workflows and improve clinical decision-making. And it gives the ability to review clinical policies and practices based on the data that's presented. Next slide, please. So how is it done at AAPHC? Everyone does their EBI or implements their evidence-based interventions differently. At AAPHC, the process is that it's a monthly rate that's given. They're sent out as monthly key performance indicators or KPIs that's sent out via email to all staff. They're emailed by the chief quality officer. Here at AAPHC, it's Joycelyn Yates, and they're reviewed by the QI committee managers and lead clinical staff. The managers and clinic directors share the results via, like I said, email to everybody, but then it's also shared at the care team meetings and huddles to all the staff, to the entire teams, and they're printed out and posted in the staff areas. And I'll show you an example of that in a moment. And finally, AAPHC employs a care team model, which is believed to allow for better team building, more seamless workflows throughout the clinic, and for healthy competition between the clinics and clinicians in the system. Next slide, please. So this is an example of one of the clinical boards that I mentioned. So all the KPIs are printed out on a monthly basis and posted in the staff areas. This is from one of the clinics, and as you can see, it's quite a bit of information. It includes all of the monthly UDS measures that are tracked, as well as patient satisfaction surveys, internal quality improvement schedules, and risk management schedules. Next slide, please. This is an example of a colorectal cancer screening table that's sent out, KPI, and where it's broken up by care team. It lists who's in the care team. Obviously, I blurred that out for privacy purposes. And also it'll give the number of patients that are in the numerator and denominator. In the actual Excel sheet that's sent out, you can go to another tab and look at the actual individual patients that are in the denominator and say it'll sort by screened and not screened. But this is an example of something that's sent out monthly where providers can see where each other are and different clinics can see, again, where they stand. Next slide, please. So now I'm going to get into the meat of the thing, the provider discussion. I'm going to quickly introduce Dawson Medical Center to everyone that isn't aware of how they came to be or how I came to be working with them. And then we'll get into the discussion with the providers themselves. Next slide, please. So Dawson Medical Center is it's one of the smaller clinics in the AAPHC family, but it's still one of the most important. It's located in Terrell County, so it's a little bit out of the main Albany area, but Terrell County, and it was the claim to fame, I suppose, is that in 2007, it had the highest rate of colon cancer mortality in the United States. And that's something that Dr. Hotz actually presented with on TV and with I think it was in CNN. They'll tell me after. Yeah. But it's also the first clinic that was implemented in the GCCRP program. And that started last February of 2021. We began, I should have edited a little bit with exact dates, but February 21, the screening rate was under 56%. Within 2 months of intervention, we reached 61%. And what's missing there is that by last October, so a year ago today, they were at 66%. And so that was all with the combination of evidence-based interventions, being part of the grants and having little eyes on there. But also they've been using provider assessment feedback for several years. So one of the things we want to discuss is the best use of these EBIs and how they're used to inform clinical decisions. And that will lead us into the discussion. So next slide, please. And so one thing I want to ask you guys as the providers, how do you feel about the efficacy of this information that you receive on a monthly basis? As all of you saw, it's kind of a lot of information. How do you deal with it? And do you think it provides motivation? Does it help you?
Me particularly, no. I don't. I find it to be just a little bit much, you know, to keep track of. It's just too much information, you know, and it's every month. Yeah.
Beth, how do you feel?
I believe it does help when you're looking at the big picture, like what do we look like as a whole? How close are we getting to the mark? Personally, sometimes it's hard for me to see are the numbers reflective of each individual provider. But you know, I do think it helps as a whole. It just leaves a little bit of room for.
Yeah, I'm more interested in how to improve what I'm doing rather than looking at the monthly numbers. You know, like for example, I got more out of this discussion, for example, than I did out of the number of feedback. Because you know, there were some ideas that I thought, okay, we haven't tried this. This is something that we could try. You know, so to me personally, that's more meaningful to me. You know, because with my daily practice, I think I'm doing everything that I can do. I don't have any control if people don't return stool cards, for example. You know, it's like, okay, we give them a reminder, we give them a stool card, and then, you know, then it's kind of up to them, somebody else to sort of remind them. So, you know, and then when you see it's not done, you ask, well, okay, what happened? You know, they waited too long to return it, expired or something like that. You know, so yeah, so the different ideas of how to improve is really more helpful to me than the actual numbers.
The numbers, they do sound good in that they're objective, and you have to have objective data to kind of help guide practice. But there's so many factors it doesn't take into account. Our particular patient population here, you know, is going to be different from one right down the road. And, you know, Dr. Dyer, he's been here a long time. He knows all the patients, knows all their names, can start describing them, and he knows them. And so, you know, seeing those barriers or knowing the patients, there's just so many facets that are not brought out by the data, you know, and we do try to use it, like you look, and that was great when we were able to see, hey, we got a jump, and that was encouraging. You know, when y'all came in and y'all started talking to us about, hey, we really need to get these numbers up. What can we do? So I believe, just like Dr. Dyer was saying, that I think having these discussions, listening to what other clinics are doing across the country and what's working to raise those numbers is for sure more helpful. But then if we could break it down and look more closely at what are some of the things that are challenges for Dawson Medical personally, and seeing what we can do to address that. So definitely helpful, but it doesn't give the full picture. It doesn't give the full story.
And then we plateaued
Right.
at a point that we, you know, wasn't that great. But we plateaued, and then we didn't really hit that peak again. So it was, you know,
Is it discouraging? Is it-
it's discouraging.
Yeah.
Discouraging. So you're like, all right,
Exactly.
you know, so yeah, that's why I go like, about the
Because I wish the numbers could take into account, and I think we had talked about this earlier, like the education piece that we put in, because each one of these patients, if there are regular patients, they're receiving the education, they're receiving the, hey, we want you to do this test and here's why. And the data of the actual completed test obviously doesn't reflect the amount of work that the providers are putting in to trying to get this screening completed. So it is frustrating. When you are putting in the work and your numbers are still staying low, so it doesn't look like you're doing anything, but you are spending an incredible amount of time offering the test, even ordering the test at times, but then we have a hard time with getting those tests sent back. Or if we're fortunate and we can order a colonoscopy, you know, the actual getting the patient to that appointment. And then of course, you know, it's usually they've got the initial appointment for the colonoscopy, then they have the actual colonoscopy scheduled. So that's 3 appointments to get that screening done. And you know, that's
Sorry, it is still a functioning clinic. So
it's still working.
But yeah, and then what's interesting is because we have a significantly high uninsured population,
Right.
and I think a good many of our patients are choosing the fit test option.
Right.
So you get them a fit test, it's completed this year, but within like 364 days, it's now out of
It's starting.
some clinics, you know. So, you know, you take colonoscopy, for example. You could be, this patient could be compliant with screening for 10 years.
right.
So when you have these large numbers of people who are sort of choosing, you know, fit test, it's literally, if you don't have it done within, you know, 12 months, you know,
Yeah.
then they're on, on compliance again. So, you know, things like that. So I, you know, yeah, that does make it challenging, you know. And yeah.
Yeah, and for everyone listening, just to be completely transparent. So as I said, a year ago today, or a couple days ago, we had hit 66 was the highest we hit, and that was within 6 months where we got to that high. Now we're currently at a 61% screening rate, so bit of a decline in a year. And to Dr. Dyer's point, that's exactly one of the issues we're dealing with in this population, that they're not coming back in a year and a day, and so they're falling out of compliance. And so that's one of the issues that we found, especially from, like Dr. Colangelo said, the FIT registry could help in that the patient reminder aspect to get them back in. But yeah, so then you did mention that it's every month. You guys aren't so much of a fan of monthly, and especially you guys saw, as everyone saw online, the wall of data that we have. There's quite a bit that they're given. For something like this, and I know like mammograms as well, where it's a multi-month process to get someone screened. Do you feel that it would be better for a different timeline, or what would be a better, I guess, visual for you guys?
to me personally, 3 or 4 at a time.
Yeah.
You know, the wall of data is, yeah,
It's overwhelming.
yeah,
It is.
3 or 4 at a time, visually, or, that's, I think, is a little bit more.
Yeah.
3 or 4 at a time. Like a page.
Yeah,
Right. And it does help when you are, as a practice, or just like they were focused on colorectal. And so a lot of time, effort, and energy was put into that specific area of screening. But when we get ours, like I was saying, we receive all of it at the same time. And the numbers just kind of, they blend in, it's difficult to pick out, well, what are we gonna look at?
Yeah, what about the rest of the screening? What about mammograms?
Right.
And pap smears? They're all important too,
Right.
so, it's not that they're saying that they're not important, colorectal is important, but the thing is that one person will get a mammogram, but they're like, not really that interested.
Mhm.
Or more likely, it's like, okay, but pap smear, no, so, those are all important too. So but the page of data is, I'm just not.
So maybe, and I think it would be helpful if it was less often. And when we did receive the data, that there was a bit of a meeting, which we don't like to meet. We like to see patients, that's what we like to do. But if for it to mean something for the providers, it would help if it was data over a longer stretch, maybe 3, 4, maybe even 6 months, to kind of see where we are. And to kind of talk about what that data looks like. I don't think a cold number of a total is very helpful on each of those.
And as far as I'm concerned, for me, it's not necessarily about what the number is then, but what can we do to get
To
it
improve it.
better? That's really key. Like I said, this discussion was far more helpful to me than any number.
Right.
Because then I guess, okay, you see the numbers. So now what? What is for me to do with this?
Right.
You mean I'm not working hard enough? Or it's like, now what?
Right.
Show me something different that I can use.
Well, Robbie, I'm gonna cut in right now and say we need to start wrapping this up. So while I'm looking to see if there are any questions out there from the audience, I did kind of want to ask a question sort of based on some of Dr. Dyer and Beth's comments. Maybe too much data all at once, but not really a focus on a few key areas. Would you do something different with your reporting? You mentioned maybe not doing it as frequently. Should there be some different focus to really focus on even the overlap between colorectal cancer, breast and cervical mammography? What would you do differently to make this more meaningful for you?
I think to make it more meaningful would be if there was provider roundtable discussion over the numbers, and as a care team, what are we doing right? What are we doing wrong? What are some areas that we see that we can do better? Because the number's not helping. If you don't do anything about a number, it has zero value. And so unfortunately, time is always a huge precious commodity for us. So doing it less frequently and getting all the providers on the same page, which I feel like we are, but just that encouragement and like, okay, well, we're getting low on this number, so we really need to work harder on colorectal this next few months, or what are we doing about mammograms? Our numbers are sliding. I think that would help.
And then for me are we employing everything that we can, that we know the strategies that has worked, that we can employ, that we haven't been using?
Right.
That's kind of like, for me, that's sort of the key. What else do we know works that we haven't been doing?
Right.
Yeah.
That's terrific. Dr. Hodge, you had a question or a comment?
Yeah, just to make a comment, I think what the people can see, and those are, and I worked with both of those folks there in a very busy clinic and tremendous social challenges. One of the poorest counties in the state and in the country. And to get to 60%, that's 50% better than most community health centers. So that's good. But, part of what you see is this information fatigue that occurs, the data being presented. What I liked about Dr. Colangelo's data, it was so clean, and I think getting clean data that people believe that they actually watch, and then making a decision about what you do about it. And we've gone through multiple cycles, but the other thing that you see, and you heard Dr. Colangelo also mention, is this fit fatigue, where every year you're chasing the fit number and maybe thinking about, Cologuard every 3 years, or, for insured people, getting them to get a colonoscopy. Because there's kind of a ceiling there, I think, that exists, especially with the population that, the very underserved population. And, the social determinants of health really hit that. Now, we are also looking at integrating some social determinants, like, so you kind of risk adjust based on the population you have too, because you've heard that also is, it's a very challenging population there in Terrell County. But overall, that's the real world of dealing with data, believing data. And what I think is so encouraging is when we look at what Dr. Colangelo has done, when you have a high functioning system, people want to get screened, you can screen them. And, when you're dealing with the population like in Dawson, it does take a lot of work. But I think a very good summary and a very good view from the field about what it's like to be in the trenches.
Thank you, Dr. Hotz. I'm actually going to call on one of our participants if she's still with us. I can't see her name, but Mary Jo Gillespie from Nebraska put a comment in the chat about their clinics in Nebraska and how providers actually, a provider actually called themselves out for having their own low performance. Mary Jo, are you still with us?
I sure am.
Tell us a little bit about how you report your information and what kind of prompted this provider to speak up.
Well, in certain clinics, it's just like you presented, where there's every provider has their own rates. And originally it started that the individual provider only knew what their rate was, and then the others were aggregate, were unnamed. But the provider was on the low end, and he said, well, I know that's me at the end. And so how's everybody else doing it? And what one of the things that came up was they're in different pods, and it just so happened that the 4 physicians on the low end were in a pod where they had all new staff. They had staff turnover. They were doing things a little bit differently because the staff was still in the process of training. So it was a good aha to show how everybody's involved in the team, how everybody is involved in these rates, not just the provider. And it just illustrated that point really well.
Thank you, Mary Jo. Of course, that's one of the evidence-based interventions that we know works, where you have different team members who have different roles along the line as they encounter the patient. Dawson, I see you got your hand back up. You got a comment or a response?
Just a quick question from Mary Jo. Sorry, I know we're short on time, so I'll be quick. You mentioned that you do it per provider. One of the issues that we were having in our discussions was that for APPs, especially in FQHCs, like they're the majority that are seen, how to kind of differentiate the APP versus the PCP who's on the patient's file and things like that. Like, how do you navigate that aspect of the numbers? We kind of get around it with the care team model here, but it is an issue because we don't have exact numbers for all the providers, if that makes sense.
That does make sense. And we, in this specific clinic I'm talking about, there were providers are linked with a specific care provider, other staffs, NPs, PAs. So we kind of knew what the team, it was more of a team ranking. So I see what you're saying though, because that can be a little tricky and that's a little harder to capture.
Thank you so much.
Mm-hmm.
All right, so it looks like Dr. Colangelo may have had to drop off. We certainly want to acknowledge his contribution today and his time, taking time with us. I will add that one of his comments about explaining perhaps why his rates, they've been able to be a little bit more successful as they are a Medicaid expansion state. So their percent of uninsured patients is extraordinarily low compared to in Georgia. And of course, Dr. Rosenbaum has asked that, let's see, how to set up a registry within the confines of our EMR so we don't need to reinvent things. Tracy, that's a great question. I know that staff have worked really hard across the state to try and figure out ways to work with the EMRs and with the providers to make sure the information is going to the right place. We're getting close to time right now. There's so much more we could discuss, but this again gives us information that we might be able to use. Dr. Islam, I'm going to turn it over to you and let you close it out.
Well, thank you very much. I wanted to inform the participants that we bring an additional benefits for the participants for the session, which is CME and CNE credit. If you would like to claim, please follow the link posted on the chat session or scan the QR code. And I wanted to thank you, Dr. Patton, for leading throughout this presentation and discussion. And also I extended my thank you to Drs. Amin and Dyer and Ms. Webb for your case presentation. Wonderful. Moving forward, we will have, need volunteers for presentation, case presentation in our future sessions. If anyone would like to bring up your particular cases, please email at au_crc screening@augusta.edu. We have sessions first Wednesday on every month. Our next session would be November 2nd. We will have the flyer with the information for the next session within next 2 weeks to you. Thank you everyone for attending, and we'll see you soon in our next session. Thank you very much. Wonderful.
Thanks, everyone.
And note to, I'm asking ECHO organizers, organizing members to stay, and rest participants can sign up, please. Thank you.